So, very good afternoon, everyone. At the outset, I would like to thank the KSOS for this opportunity. And more importantly, I would like to thank all the audience who are still waiting here and checking the OPL for us. So, uh, this instruction course, we were talking about the different shades of macula. So, macula is the most vital region for central vision. And hence, early diagnosis and treatment is very essential for maintaining the central vision. So, in this instruction course, rather than delving into each macular pathology one by one, we decided we'll take it at a single go. So, what we decided is we'll look at the clinical findings, such as the membrane over the maculas, the fluid at macula, the pigmentation, the hemorrhages at macula, and the hard exudates and yellow lesions that you see there. So, I'll be talking about fluid at the macula, blue as the ocean. So, when we talk about fluid at the macula, right, you as a ophthalmologist, most of us can easily diagnose fluid at the macula. You can see that there's some fluid at the macula. This is an NFOS view. You need a cross-section view to actually identify where this fluid is located. So OCT helps us. And quite honestly, gone are the days when we say that OCT is like, no, it's a luxury. It is a very must needed as of now for an ophthalmologist. So when you look at an OCT, you can have the fluid at the below the retina, that is subretinal fluid, or you can have within the retina, that is the intraretinal fluid, or you can have a combination where you have intraretinal fluid as well as subretinal fluid. So let's look at this pathologies now. Now, if you see this patient is, you can see a fluid right here, the greenish lesion. This is a multicolor image. So when you see this greenish lesion in a multicolor image, that indicates that the lesion is elevated. So you have fluid over here, and this is the zoom view where you can see the fluid here, and you can see some lesion over here. So what do you do about this? Now let us look at the OCT. So if you run the OCT over here, you can see the schisis over here in the retina. And as you reach this lesion, you can see there's a break here. So you see such a condition, the treatment is not medical, it is purely surgical. This patient will require a surgical intervention. So there's no point of loitering over there. You have to refer it to a VA surgeon. Now, another case where you see the subretinal fluid, you see as a fluid as there in the macula. And when you do the OCT, you can see the, as you run the OCT, you can see the serous PED here, and you could see some amount of trace of fibrin there. And the choroid is thickened. So this is a case of central serous retinopathy. Now, what are the investigations that you want to do? You would like to get an autofluorescence. OCT is must required. You can do an OCTA, especially in chronic CSRs. OCT is very important to diagnose CNVMs. You can get an FFA ICG to look the leak. And most important thing, when you see a central serous retinopathy, the treatment is medical only except for one condition, because what happens is the moment you see the fluid at macula, we forget to look at the disc, and you might have an optic disc pit there. And when you have optic disc pit, the treatment is surgical and not medical. The treatment usually is observation. You can use, there's no point of trying out non-steroidal anti-inflammatory drugs there because there's no inflammation there, right? So rather than giving NSAIDs, you can actually try dorzolamide carbonic anhydrase inhibitors. Focal laser, after doing a FFA, if you see that the leak is away from the fovea, you can do focal laser. PDT, sadly, we don't have that anymore. If you have a central leak, you can try subthreshold lasers. And in certain cases, you can also try medical management such as eplerenone. But the only problem is when you start eplerenone, you have to have the patient monitored for hyperkalemia and electrolyte imbalance. Now, this is another case where you see multiple pockets of SRF over here, right? Now, this is the OCT. Now, as you see the OCT here, you can just see this over here. So this is if you see the RP over here, in central serous retinopathy, you could see a PED and the RP was completely flat. Whereas you can see the RP is not exactly flat. There is some amount of undulation there. And along with that, this sign over here, this is called as a Ballard. There's a basilar detachment, and you can see the multiple pockets of fluid there. Okay. So we did an FFA for this patient, and you can see the starry sky pattern. This is a case of VKH, where the investigation that you require is a color fundus picture and an FFA. And the treatments are usually systemic steroids and immunosuppressives. This is another case. There's a huge, large macular fluid over here. You get an OCT done for this patient. Now, at this point of time, you see a large, huge PD. The first thing that you might think, okay, fine, this is probably a case of central serous retinopathy. But as you see run through the scan, you will see this. The PD is okay, fine. This is serous still here, but this sign over here, that is a notching of notch PED. And when you see a notch PD and the flat PD, irregular PDs over there, then probably you're looking at a case of polypodal choroidal vasculopathy. So the investigation required a color fundus picture. You can do an OCTA where you can see the network in most of the cases. That is a branching vascular network and a small amount of polyp in some amount. If you do a manual segment, FFA ICG still remains the gold standard for PCV. The treatment is anti-VEGFs, and usually in such cases you require normal ranibizumab will not do well. You will have to go for the higher anti-VEGFs such as brolucizumab, aflibercept, or faricimab. Now, this is another kind of case that you very commonly see. This is one of my patients who had a branch retinal vein occlusion, had a neovascularization for which the laser was done. This patient again came with a recurrent retinal hemorrhage. So this is a branch retinal vein occlusion, and when you do the OCT, you can see the intraretinal fluid over there, CME over there. So whenever you see such cases, systemic evaluation is very important, that we all know that. But what happens is many times again, like I said, when we look at the macula, we tend to disregard the disc. And you know, sometimes the cause for the retinal vein occlusion might not be systemic factor, but the local factors such as glaucoma. So get a color fundus picture. OCT definitely is important. OCT and FFA is actually required when there's not much macular edema and if you're suspecting a macular ischemia. So treatment for such conditions are anti-VEGFs, or you can, since these conditions are very notorious to having recurring CMEs, intraretinal steroids such as dexamethasone implants are very useful, and the role for lasers are only when there's neovascularization. There's another case. You can see the diabetic patient. You can see a lot of hard exudate there. This is the OCT. And when you see the heart, you can see a lot of intraretinal fluid over here. You can see hard exudate clumps over there. So this case is required. This is basically a case of diabetic macular edema. Color fundus picture is very important. Do an OCTA if you're suspecting macular ischemia, and also do the FFA. Treatment, when you see do an FFA, you can see leaking aneurysms. So gone are the days when you used to do grid lasers. If you see leaking aneurysms, you can do a focal laser to them. In such cases, the case that I showed you, where there's a lot of hard exudates threatening the fovea. So yes, you can do focal laser there. You can do give anti-VEGFs. Intraretinal steroid is usually a preferred modality when you see such hard exudates. And there's another case. So in this case, you can see a fibrovascular PD there, subretinal fluid. This is intraretinal fluid, and there's some amount of subretinal hyperreflective material. This is basically a case of macular neovascularization. OCTA can be used to diagnose the network. FFICG can be done, and treatment is usually anti-VEGF. So the take-home message is, gone are the days when you have to totally rely on your clinical examination only. You will require the assistance of OCTA to get a cross-section of the pathology there. And yes, when for most of the cases, almost majority of your cases, you can diagnose on the basis of clinical examination and OCT. And there are certain cases where that is not enough, and you might have to rely on dye-based angiography or OCT angiography. Thank you. So next I call upon Dr. Indu. She'll be talking about macular hemorrhages.
Good evening, everyone. I thank Dr. Rahul for giving me this opportunity. So we go to the topic. Crimson skies, macular hemorrhages. So macular hemorrhages occur due to alterations in the retinal or choroidal circulation. So why is characterization important? One, it gives a clue to the clinical condition, and two, it is a diagnostic sign for an underlying systemic vascular disorder. So based on in which layer the hemorrhage happens, it can be divided into subhyaloid or pre-retinal hemorrhage, sub-ILM bleed, an RNFL bleed, intraretinal bleed, subretinal and sub-RPE bleed, and very rarely they can be mixed bleeds which happen in multiple layers. Now first coming to the subhyaloid hemorrhage. Subhyaloid hemorrhage has got a characteristic boat or a D-shaped shape. It happens between the posterior limit of the eye of the vitreous and the internal limiting membrane of the retina. And because of gravity, the red blood cells gravitate down and forms a horizontal blood level at the top. So the blood can also shift with the position of the head. And on OCT, you can see a high reflective membrane indicating the posterior hyaloid, the red blood cells posterior to it, and you can see the details of the retina to a certain extent. A sub-ILM bleed occurs between the taut ILM and the retinal nerve fiber layer. Because it's trapped under the taut ILM, it does not move with the position of the head and it is dome-shaped. So this is a sub-ILM bleed. There are a few signs that you can look for. One is called as a double ring sign when there is both a sub-ILM as well as a subhyaloid hemorrhage. 2, an exclamation mark sign, which is a glistening light reflex on the ILM. And 3, an arcus retinalis, which is a white ring at the edge of the ILM bleed. So this is an OCT of an ILM bleed. You can see the taut ILM which is separated, and the blood is so dense it causes shadowing posteriorly. So when you differentiate between a subhyaloid and sub-ILM, a subhyaloid is boat-shaped, sub-ILM is usually dome-shaped. A subhyaloid shifts with the position of the head, whereas sub-ILM does not shift. Subhyaloid resolves faster because it's amenable to treatment better. And 2, the sub-ILM does not resolve so fast. And for a subhyaloid hemorrhage, the underlying retinal layers are typically visible on OCT, whereas in a sub-ILM bleed, the underlying retinal layers are often obscured. Now coming to the retinal hemorrhages, the first one will be the superficial hemorrhage or the RNFL hemorrhage, which is called as the flame-shaped hemorrhage. It is flame-shaped because it follows the parallel construction of the ganglion cells and the distribution of the RNFL. It lasts approximately 6 weeks and typically occurs due to pathology of the superficial retinal capillary plexus. In contrast, we have a deeper hemorrhage which is called as intraretinal hemorrhage or the dot and blot hemorrhage. It happens in the inner nuclear and the outer plexiform layers of the retina. It is dark red, sharply outlined and dot or blot shaped. It tends to happen in the deeper layers, more compact layers of the retina, and hence it cannot spread out like a flame-shaped hemorrhage. It happens due to disorders of the prevenular deep capillary plexus. So when you consider the OCT of a flame-shaped hemorrhage will show a very high reflective spot in the superficial retinal layers with posterior shadowing, whereas deeper hemorrhages are smaller and they appear as hyper-reflective lesions with posterior shadowing. Now coming to the deep layer hemorrhages, the first one is a subretinal hemorrhage. A subretinal hemorrhage happens between the photoreceptor layer and the retinal pigment epithelium, and because it is not constricted by the RPE, it spreads out and hence its borders are usually indistinct. The hemorrhages are deep red in color and you can see the retinal vessels going over it. In contrast, a sub-RPE hemorrhage happens between the RPE and the Brooks membrane. It appears dark and it has got a well-defined sharp border because RPE limits the spread of the blood. So here you can see there is a deep layer hemorrhage, and on OCT you can see that the blood is both in the subretinal as well as in the sub-RPE component. It has got a sub-RPE and sub-retinal component, and because there is blood in the sub-RPE component, there is shadowing posteriorly. So how will you differentiate between these? Subretinal blood is bright red, whereas sub-RPE blood is usually darker and sometimes even black in color. Subretinal blood is more harmful to the photoreceptors, whereas sub-RPE blood is less toxic because of the limiting effect of the RPE. And subretinal blood is more amenable to displacement, whereas sub-RPE blood is poorly amenable to displacement. Now, coming to approach to macular hemorrhages, in here you have to consider the type of the hemorrhage, the bilaterality, the age, and what treatment you are going to give. Depending upon the type of hemorrhage, subhyaloid and a subhyalum bleed usually have a similar pathology. They're most commonly caused due to a valsalva retinopathy, PDR, Terson syndrome, trauma, and blood dyscrasias. Flame-shaped and dot and blot hemorrhages usually have a common pathology, usually due to systemic vascular problems like hypertension, diabetes, occlusive diseases, even blood dyscrasias. And subretinal and sub-RPE bleed can again have a similar pathology, most commonly due to neovascular AMD, PCV, RAP, or trauma. Mixed bleeds, when bleeds happen in multiple layers of the retina, it is called as a mixed bleed. So, for example, you can have both flame-shaped as well as dot and blot hemorrhages in vascular disorders like diabetes, hypertension. You can have all layers bleed, that is subretinal, intraretinal, and preretinal bleed, specifically in conditions like RAM and trauma, as well as in valsalva retinopathy. You can have both subhyaloid and subialum bleed in valsalva, Terson's, and trauma. Now, trauma in any age can cause hemorrhages. Trauma can cause retinal hemorrhages in any age group. But if you see bilateral hemorrhage in very small children, you have to think about a child abuse. If you see hemorrhages in young adults, you have to more think in terms of valsalva, hematological conditions, blood dyscrasias, and autoimmune conditions. And if you see bilateral hemorrhages in a little middle-aged or elderly patients, you have to think about systemic vascular disorders like hypertension or diabetes. Now, coming to treatment, when you go, before to think about treatment, you have to go through a thorough history, that is regarding medication use, history of trauma, or performing a valsalva maneuver, history of using anticoagulants. Then you can even do a systemic examination, including a peripheral smear and coagulation profile, and do a multimodal imaging, including OCT, fluorescent angiography, and ICG angiography if required, as well as a fundus photography. Now, how will you treat? Now, coming to subhyaloid and subialum bleed, if it's a small hemorrhage and it's not vision threatening, you can observe. Whereas if it's a dense bleed, severe vision loss, and acute onset with a clear media, you can consider ND-YAG laser hyalodotomy. If it's a dense bleed, you have to consider pars plana vitrectomy. So in a YAG laser, you make a small nick in the posterior hyaloid so that the blood drains into the vitreous. However, you have to warn the patient that even though there can be an initial improvement, if the vitreous hemorrhage spreads, it can again cause a further drop in vision and he will require vitrectomy. So this is a patient who presented with a young patient presented with a non-resolving vitreous hemorrhage. After doing a pars plana vitrectomy, you find that there is, so the vitrectomy is being done. You find that the ILM is very taut and there is blood debris under the ILM. So it was actually a sub-ILM hemorrhage which had broken through to a vitreous hemorrhage. So the ILM is being repealed. So you can see the debris under the ILM. It's actually the RBCs, and that is also being removed. And fluid gas air exchange is being done. For a frame-shaped and an intraretinal bleed, no direct treatment for the hemorrhage is required. It's actually the treatment of the underlying cause. For a subretinal and a sub-RP bleed, so small bleeds, you can treat it with anti-VEGF injections alone with or without focal laser or PDT. But large bleeds require pneumatic displacement because blood is toxic to the retina, with a TPA or followed by anti-VEGF injections. If there is a breakthrough bleed, you will require pars plana vitrectomy with a subretinal TPA. So this is an example of a subretinal bleed which has undergone pneumatic displacement with TPA, tissue plasminogen activated TPA, followed by anti-VEGF injections, and you can see the significant improvement in the OCT. Thank you.
Thank you, Dr. Indu. So next, Dr. Shishir will be presenting on the membranes at the macula. Since he's occupied in the OPL, so he has shared his video over here.
I'll be presenting Green Valley membranes at the macula, and I would like to thank Dr. Rahul for including me in this instruction course. So I'll be talking on vitromacular interface disorders. So the presence of an incomplete PVD is the reason for the vitromacular interface disorders. So when you have an incomplete PVD, it may be attached at the disc and the macula, or may be detached from the perifoveal region. And usually this attachment is extremely strong at the fovea, which over a period of time causes anterior posterior traction, and then this finally leads to a macular traction. So vitromacular adhesion. Vitromacular adhesion is of two types, focal as well as broad. So in such cases, you can see on this OCT scan, the posterior hyaloid just touches onto the macular surface. It's a focal vitromacular adhesion, and then if you have a broad-based adhesion, it's a broad adhesion around more than 1500 microns of the area. If it touches onto the macula, then that's a broad adhesion. So here patient usually doesn't have any symptoms and they usually come with good vision or for a routine examination. So here no intervention is required and just need to ask the patient to follow up. So what is vitromacular traction? So that is a complication of a partial PVD. So the partial PVD is the cause of why this VMT happens. So here the vitreous is adherent in a broad dumbbell-shaped region encompassing the macular area. As you can see here on this scan, the posterior hyaloid is detached in the perimacular region, but right at the fovea, it is causing a anterior posterior traction, leading to a shallow cystoid space as well as a subfoveal detachment. VMT does progress. So once a patient comes with a VMT, the vision will initially be good. So in this case, you can see this 75-year-old male with good vision, 6 by 6. He had VMT at initial presentation, was asked to follow up routinely, did not come, came after a year with vision drop. He had vision of 6 by 12, and then he had a VMT with the outer lamellar hole which developed over there. So then the question arises, do all OCT diagnosed VMT require treatment? The answer is no. So most cases of VMT syndrome, they have good vision and mild tolerable metamorphopsia and do not require treatment. But however, we need to emphasize to the patients that the follow-up is the most important thing there. So, what are the indications for treatment? Vision is a very important biomarker. If you operate the patient with good vision, sometimes there's a risk of vision drop even after surgery. So, patient counseling is extremely important. So, only if the patient is symptomatic, we need to treat. If there is disturbing metamorphopsia, we can treat. Or if once the vision has reduced, so just because OCT is showing something, and the vision is good and the patient is not having any symptoms, then we don't need to treat such a patient. So now let's come to the epiretinal membrane. So epiretinal membrane is also a consequence of PVD. So I'm talking here about idiopathic epiretinal membranes. So we have the stage 1 epiretinal membrane. Stage 1 ERM will have this hyperreflective membrane onto the retinal surface there, and then foveal depression will be normal. A stage 2 ERM, there will be loss of the foveal depression, and you can see the outer nuclear layer will be appear slightly stretched over there. And most of these patients are still asymptomatic in this stage, and few of them will have these cystoid spaces. And then we have a stage 3 epiretinal membrane. That's when you have the formation of this ectopic inner foveal layer. So it's basically nothing but a hyperreflective band which extends from the inner nuclear layer and inner plexiform layer, and it spans the foveal region. So what this means is the fovea kind of develops an additional layer. It's like a negative prognostic factor. Like if you operate at probably at this stage, then the vision may not improve so significantly after surgery. And then the one more sign which is found in the epiretinal membranes is this cotton ball sign. It is like a round and fuzzy hyperreflective lesion which is seen at the photoreceptor layer or at the interdigitation zone. So this can predict decline in visual acuity over a period of time. And next, finally, we have this stage 4 epiretinal membrane. So here there is absence of foveal pit. There is presence of the ectopic inner foveal layer. And you can see there is like drill-like picture. There is disruption of these inner layers, which you can see here on this OCT there. And they usually, even after you do the surgeries, some of them, they don't have good post-operative visual outcomes. Occasionally, ERMs can be secondary to a retinal disease. So in this patient, we can see a tributary vein occlusion, a chronic one, which has led to a epiretinal membrane formation along with some hemorrhage. And the contraction of that fibrotic epiretinal membrane has caused these paralamellar defects you can see in this fundus photograph. Also on the OCT, you can see the disruption of the layers along with the presence of the fibrotic epiretinal membrane. The next is a tractional lamellar hole, which is a separation between the outer plexiform layer and the outer nuclear layer, which creates a schisis-like appearance. So it's a mustache-shaped appearance of at the fovea, what you see there here on the OCT. And as the ellipsoid zone is intact here, usually patients will have good vision. So next is a degenerative lamellar hole, which is like a large cavitation extending into the outer retinal layers as you see. So here the disrupted ellipsoid zone and it can be disrupted and there can be presence of a foveal bump, and it's also called as a top hat appearance. And if you see closely on this OCT, these two membrane-like things just at the edge of the hole, they're called as lamellar hole associated epiretinal proliferation. So I'll just briefly touch upon other membranes which we see in proliferative diabetic retinopathy, which can be from focal membranes to quite extensive, even extending beyond the posterior pole, as you see in some of these cases here. So we can have a tractional macular hole in diabetics where the membrane is pulling one lip of the hole open up like that, along with some presence of subretinal fluid, like what you see here. So this is a PDR tractional macular hole. It can present with a tractional retinal detachment as well as a tractional lamellar hole formation, what you see here. And also it can be present with tractional diabetic edema, where you can see cystoid spaces at the fovea there with this dense fibrovascular proliferation. So the decision to treat in cases with proliferative diabetic retinopathy, when you have these membranes, is especially when the vision is significantly reduced, when there is a fovea threatening TRD, or when there is a tractional diabetic macular edema. And just a slide on some honorable mentions. Even membranes can present at the macula in the form of a proliferative vitreoretinopathy in cases with retinal detachment. So here you can see in this case, I'm removing these PVR membranes from the posterior pole. And another honorable mention, sometimes when you leave silicone oil inside the eye for too long, you can have these inflammatory membranes which develop. To conclude, an incomplete PVD is the culprit for most of these vitreoretinal interface disorders, and an OCT is extremely important in picking it up early. So, asymptomatic vitreomacular tractions can be observed. It's important to know the staging of epiretinal membranes as well as to know regarding the biomarkers, as we mentioned in this PPT. And also, visual acuity is an important predictor and a good decision maker is when to do the surgery. And most of these patients, they come for cataract surgery, and an OCT is a good tool to know the status of the vitreomacular interface before planning a cataract surgery. Thank you for your attention.
So next I call upon Dr. Lekha. She's a senior retinal consultant at Giridhara Institute, Cochin. So she'll be talking about yellow lesions at the macula.
Thank you, Dr. Rahul, for giving me an opportunity in this colorful IC. So my topic is approach to yellow macular lesions. The most common yellow spot that we see is actually the physiological spot, which is macula lutea. The yellow color is due to the carotenoids lutein and zeaxanthin, which is a very important protective role in our eye. But we also see a variety of pathological yellow lesions of very wide-ranging etiology, and we'll try to look into some of this in more detail. So we will start with drusen and hard X-rays, which are the most common yellow lesions that we see. And very often for the beginner, there can be a little doubt as to whether it is a drusen or a hard X-ray when they see an yellow lesion. Drusens are typically dull yellow, randomly spread, whereas hard X-rays are more bright, well-defined, and see in either clumps, circinate, or stellate patterns. And definitely OCT help us to know their location, which is sub-RP or subretinal in drusen, whereas it is intraretinal in hard X-rays. While drusen is a hallmark of age-related macular degeneration, hard X-rays are commonly seen in vascular diseases due to various reasons. Now, we look into drusen in little more detail, which is the first lesion that define AMD. So, age-related eye disease study have classified drusen into hard, soft, and calcific drusen. It's not enough if you just see the drusen, we should know the implication. Hard and calcific drusen can predispose to atrophy, whereas soft drusen can precede PED and CNV, which is more ominous. In these patients, when you see such findings, we should give them appropriate advice in the term of lifestyle modification, avoiding smoking, use of anti supplements either naturally through their food or antioxidants, and monitoring their vision with Amsler grid. And with the help of OCT, we can evaluate these drusen's in more detail. And this is important because the various biomarkers for progression to advanced AMD are the drusen size, area, height, and length. If there is increase in the height, it is more risk for GA, geographic atrophy, whereas increase in the length is a risk for CNV. Now, there are other yellowish lesions that may not be recognized always. You can see very fine dot-like yellow lesions. And on OCT, you can see that it is actually internal to the RPE, looks like subretinal granular hyperreflective material associated with a thin choroid. And this is what we see in pseudodrusen because it is under the retina and not under the RPE or subretinal drusenoid deposit. And this is another drusen, which is larger, and it is under the RPE and with thick choroid, which we call it as pachydrusen. It's important to identify because pseudodrusen can predispose to neovascular AMD, whereas pachydrusen predispose to PCV and CSR. Drusen is a common finding in those above 50, but when you see drusen-like lesions in those less than 50, let us give little more attention. It can be cuticular drusen when there is numerous small dot-like lesions, and this is in the spectrum of AMD. Familial dominant drusen typically has a radiating pattern and it also involves nasal to the disc. It's basically a genetic condition. And these large colloidal drusen looks large, but they generally have a good prognosis. Again, when you see extensive drusen-like deposits, we should also look into the systemic status because they can be associated with renal problems, SLE, chronic inflammations, etc. And one point to differentiate it, they may not show hyperautofluorescence on FAF imaging. And any patient less than 50 years with significant drusen, please evaluate their renal status. Now we move on to hard exudates, which typically seen in succinate pattern and can be in wide range of etiologies. This was in a case of DME, this was RVO, this is PCV, and this is AMD. So wherever there is capillary endothelial damage and breakdown of the inner blood-renal barrier, it can lead to leakage of the lipoproteins and formation of hard exudates in a succinate pattern. So not all hard exudates mean it is DME because most of these cases are referred as DME, especially if there is a history of diabetes. We should try to understand the etiology of the hard exudates and then give the appropriate management. So this is a 64-year-old lady, came with blurred vision. You can see extensive yellowish lesions in the posterior pole. We were not sure FFA and OCT did not show any features of inflammation, but her blood workup gave us the answer, alarmingly high lipids, and with systemic treatment, she improved very well. Now we move on to the yellow lesions with subretinal fluid. These are three different situations. How do we proceed? The first case is a young male came with central scotoma. OCT shows subretinal hyperreflective material with a vacuole sign. FFA showed ink blot leak, no network on octa. So this is CSR with fibrin, which was giving that yellow appearance, and he responded to focal laser. This is a little more elderly lady with defective vision. There is subretinal hyperreflective material or SHREM. There was typical classical type of leak on FFA and ICGA, network on octa, suggestive of AMD with classic CNVM, and this has to be treated with anti-VEGF. And the third case is again an elderly patient. He was actually treated as CSR with eplerenone in US. So when he came to us, in the OCT, we could really pick up the findings of double layer sign, tall PED, hotspot on ICGA, and a network on octa suggestive of polypoidal choroidal vasculopathy, and he also responded well to anti-VEGF. So yellow lesions can occur in AMD, PCV, CSR, and with multimodal imaging, we can definitely differentiate these conditions. We will move on to the next spectrum. Again, two different patients with a prominent yellow lesion in the macula. Second case, the lesion was looking little elevated with a lot of SRF. OCT in the first case gives us a full thickness retinitis, so most likely it's a toxoplasma. Whereas in the second case, you can see an elevated choroidal lesion with subretinal fluid with a contact sign indicating it is a TB choroidal granuloma, and both resolve with treatment. Of course, in retinitis, you get a scar. Granuloma may resolve completely without any residual changes. So inflammations, if it is more bright yellow, and it is ill-defined and superficial, it is more likely retinitis, where if it is more deeper, little more dull yellow and well-defined, it's likely to be choroiditis. And definitely with OCT, it's not a big difficulty to differentiate the two. This is a young boy with multiple small yellow lesions, which was initially superiorly, then it became temporally, then it became more closer to the macula. OCT showed outer retinitis with the hyperreflective dots in the vitreous. So this, because the uveitic workup was negative, we diagnosed it as presumed diffuse unilateral subacute neuroretinitis or presumed DUSN. So when you see these retinitis lesions, we should try to differentiate and understand the etiology. Small punctate lesions can be Behçet's, DUSN. If it is large patches in the periphery, it is ARN. Full thickness lesion is toxo. Outer retinitis is more syphilis or DUSN, and inner retinitis is post-fever retinitis. And OCT again is useful. This is another patient with multiple, little more larger yellowish lesions, discrete initially, then became confluent. OCT showed changes in the outer retina, RP, and choroid. FFA showed early hypo, late hyper. ICG showed hypo. So this was actually multifocal choroiditis, and we should try to differentiate the etiology, whether it comes into the white dot syndrome or stromal choroiditis. The next spectrum, we have bilateral similar yellowish lesions with very characteristic hyper autofluorescence on FAF, and hyperreflective material on OCT. Diagnosis is for sure it is autosomal dominant Best disease. This is another patient with multiple vitelliform lesions and subretinal fluid. This is in the same spectrum, but it is autosomal recessive Best retinopathy. So whenever we see such bilateral symmetrical lesions, younger age of onset, we should evaluate them for dystrophies. This again, as we can see, the typical flex either in the perifoveal or more extensively suggestive of Stargardt's, but we should try to differentiate them from drusen. Drusen is more round, whereas the flex are more elongated or pisiform. Mass lesions can also be seen, as in this case, and seen on the OCT with a kind of lamellar pattern, but ultrasound showed a hyperechoic lesion with shadowing, which was due to choroidal osteoma. And this is again elderly patient with multiple yellow lesions. You can see the typical lumpy, bumpy appearance of the RP, suggestive of primary vitreoretinal lymphoma. This is a young boy, unilateral high myopia, -9 with amblyopia. And this yellow appearance was due to the myelinated nerve fiber, suggestive of Stratsma syndrome. And this is a triad of the syndrome. So when you see common retinal yellow lesions, it's a very common finding in the elderly, but in the young, it should be more significant. Try to characterize the lesions so that it will help you to understand the etiology, which can be a specific problem or non-specific like heart disease or rare conditions like masquerade, and a systematic approach is important. Before I conclude, I want to show one last case, which is a curiosity. He had bilateral retinal hemorrhages due to anemic retinopathy, and FAF showed hypoautofluorescence, which was expected due to the blockage from the blood. The hemorrhages resolved, leaving an yellow spot at the fovea, and it showed a hyperautofluorescence, and I did not know. Ideally, it should be blocking the fluorescence. So then I searched and found that this yellow spot is due to bilirubin from devitalized blood, and it is an endogenous fluorophore. That is why it caused hyperautofluorescence. Thank you.
Thank you, Dr. Lekha. Next, I call upon Dr. Basil. He's a veterinary surgeon at Lotus Eye Hospital, Cochin.
Good afternoon. First of all, I would like to thank Rahul for giving me an opportunity to present here. So today I'll be talking about the pigmented lesions in the macula. So basically it will be geographic atrophy, ocular toxoplasmosis, macular telangiectasia, choroidal melanoma, and drug toxicity. So as you know, in AMD, the geographic atrophy is the most advanced stage of the dry AMD, and it often spares the fovea until the last stage. So the visual acuity is relatively good, but when the fovea becomes progressively atrophic, it leads to severe vision loss. So what happens is you see unmasked choroidal vessels which are more readily visible. The overlying outer retina appears to be thin, and the choriocapillaries are attenuated and atrophied. On FFA, the geographic atrophy seems to be well circumscribed, round to oval window defects, and there is dense hypoautofluorescence occurs in the area of geographic atrophy. And the fluorescent angiography is a very practical and non-invasive tool to monitor the progression of geographic atrophy. In the SCOCT, there is a loss of RPE, inner segment ellipsoid, and the photoreceptor layer. And the fundus photofluorescence, it changes over time. And here you can see that in the left side, this is the earliest sign. And in course of time, this patch had increased in size, and it becomes bigger, and the geographic atrophy progresses. And also it is important not to just look at the area of the atrophy, but also to look at the area of the hyperautofluorescence. We should also look at the configuration, like whether it is a single patch or whether there is multiple patches, and also whether it is involving the fovea or extrafoveal area, and even the size also matters, because all these will determine the progression of the disease. And the other factors include the multifocal areas of atrophic changes. It progresses faster, and the bigger areas of geographic atrophy also progress faster. And the pattern of hyperautofluorescence around the dark area also have higher progression. So the progression rates, if it is a single dark patch, it usually progresses around 1 millimeter square per year. But if it is multiple small patches, it progresses around 5 times faster. Now, coming on to the ocular toxoplasmosis, as you know, it is caused by Toxoplasma gondii, in which cat is the definitive host and humans are the intermediate host, and it can be either congenital or acquired. So the signs includes the anterior uveitis, and in posterior segment, you see the vitritis is just headlight and fog appearance. So the most distinctive feature in congenital toxoplasmosis, there is a large atrophic chorioretinal scar, And the scar is often described as a wagon wheel macular scar or punched out chorioretinal scar. And the visual acuity will be remarkably good because of the eccentric fixation, and the depth of the lesion is so large that involves the fovea. And retinochoroiditis will occur in 75% of the cases, and it may be detected early in the, later in life as an incidental finding. And the satellite lesion, the retinochoroiditis, is associated with the pigment scar, and it is known as the satellite lesion. And the lesions will always tend to involve the posterior pole. And the healed lesions in which the border becomes more defined and and it remains hyperpigmented after several months, and the large scar will always have a atrophic center. Now, coming on to the investigations, the OCT, it is done to demonstrate if there is any macular edema in case of vitritis. B-scan is done to exclude any RD in case of severe vitritis. The fundus autofluorescence for monitoring the inflammatory activity, and fundus fluorescent angiography to look for any vascular occlusions. Now, coming on to the melanoma, the mean age of presentation is about 45 years. It is rarely seen in children. And the choroidal melanoma is not actually black, but it can be gray or brown. And it starts a dome-shaped lesion. And the symptoms include blurred visual acuity, paracentral scotoma, floaters, and severe ocular pain. And the tumors, they can be either small, medium, or large. And the diagnosis is basically by the clinical appearance. FFA, ultrasound, and radiography is also done. And these are the various type of melanomas. It can be either highly pigmented melanoma, amelanotic melanoma, orange pigment on the surface, collared, diffuse melanoma, or the one with the exudative RD. And in fundus fluorescent angiography, it shows double circulation. It's that the overlying retinal vessels and the underlying tumor vasculature can be seen. So that is known as the double circulation. And the melanoma is composed of thickly laid tumor tissue with lots of pigment. So it shows less leakage. The MRI is done, and melanoma appears hyper in T1 and hypo in T2 image. And now, when should we know whether it is a nevus or a melanoma? When all these factors, these indicate this lesion is actually proliferative and it is not actually nevus. The melanoma can arise from choroidal nevus, and if we are looking for suspicion, we should look for all these signs and whether it is converting to melanoma. So small melanoma is usually treated by transpupillary thermotherapy or brachytherapy, and the 6% mortality is for 5 years. And medium melanoma, the treatment is usually brachytherapy, and for large melanoma, it's enucleation. Now, coming on to the macular telangiectasia, it's an idiopathic macular telangiectasia is an uncommon disorder which is characterized by telangiectatic vessels in the juxtafoveal region of one or both the eyes. So the gas divided into 3 groups. The type 1 is unilateral, which is characterized by parafoveal dilatation of the capillaries. Type 2 is the most common, bilateral juxtafoveal telangiectasia with minimal exudate, and type 3 is an extremely rare, characterized by occlusive telangiectasia. Now, this is the group 1 in which you see no clinical abnormality and the FFA shows late leakage. This is the stage 2 in which you see a grayish sheen over the parafoveal area, and the FFA shows early hypofluorescence, and its late phase shows diffuse retinal staining. And the stage 3, there is numerous superficial retinal crystals and vessels ending with right angle venules. And the FFA shows visible dilatation and telangiectasis of the perifoveal capillary network beneath the right angle venule, and late intraretinal staining. And this is the stage 4, which is the hyperpigmentation around the foveal area. And the early stage, early stage will show intraretinal pigment epithelial deposition in the vicinity of the temporal right angle venule. And the stage 5 is a stage of choroidal neovascular membrane development. Now, the IJT, the typical feature is a thin drape-like structure which is seen over the fovea, which is known as the ILM drape sign. And there is a hyporeflective inner retinal cavitation, and there is also an ISOS disruption. Now, the other condition is drug toxicities, for example, HCQ toxicity. Here, what you see is the bullseye maculopathy with concentric ring of hyper or hypopigmentation surrounding the fovea. And the fundus autofluorescence will show early parafoveal or extramacular photoreceptor damage as an area of increased autofluorescence. And the OCT will show the satellite sign, this flying saucer sign. It is actually the preservation of the subfoveal ISOS junction with parafoveal ISOS loss. And the multifocal ERG, there is a pedicentral amplitude depression and central amplitude reduction, which can happen resulting in the generalized loss of the vision. There's another condition called the solar retinopathy or the foveo-macular retinitis. It's a thermally enhanced photochemical retinal injury caused by direct or indirect gazing at the sun, and it occurs when you view at the solar eclipse without without an eye protection. And it is not normally seen, but it can be seen in exposed to solar eclipse or welding arc light. So this is the small, not actually pigmentation, but this is a picture showing that idiopathic juxtafoveal telangiectasia, and the fluorescein angiography on this eye will show telangiectatic changes in the temporal macular area. Okay, thank you.
Thank you, Dr. Basil. So we still have some time. So we're open to any questions from the audience.